Hello, everyone. Thank you for joining us today. I hope you can all hear me loud and clear. My name is Maddie Curry. I am a public health program coordinator with the National Indian Health Board. Thank you all for joining us today again. I'm going to give folks a couple more minutes just to get sorted in, and then we'll go ahead and get started. Alrighty, I guess we will go ahead and get started. Thank you again, everyone, for being here today and joining us at the 2022 National Tribal Public Health Summit. Again, my name is Maddie Curry. I am a public health policy and program coordinator with the National Indian Health Board, and I am the coordinator for our maternal mortality prevention projects. And today is one of a series of events that we have been hosting around maternal mortality prevention. And we are seeking to build upon maternal mortality prevention efforts in education and making our national audience aware of the maternal mortality prevention efforts that are currently being done in Indian country. And that is one of the, that is why we are here today, to talk about the role of doulas and traditional birth workers in strengthening maternal mortality prevention. So I wanted to start with a quick land acknowledgement. We are currently coming from the, presenting to you from the Washington, D.C. area, and that's the unceded lands of the Nacotchtank and Piscataway peoples. And we would also like to recognize that maternal mortality prevention is a very sensitive topic, and this might affect some participants more than others. We encourage those impacted by this issue to connect with your support networks. And I just wanted to go over some quick housekeeping rules. This workshop is being recorded right now, and it will be posted online after the conference concludes. If you do not feel comfortable being recorded, please leave now, and we will be sure to let you know when the workshop is posted. Please go ahead and keep your microphones muted unless you're prompted to ask a question during the discussion portion of this. Again, if you have questions, please use the chat box, and we'll have questions at the end of this, not presentation, but discussions. And then there's also going to be an evaluation after this conference in your in the Pathable webpage of this event. If you could please take two minutes or so to fill that out, we would really appreciate it. It helps us learn and make our next events that much better for you. Okay, so just to provide some context before we dive into talking about the role that traditional birth workers and certified nurse midwives and doulas can play in maternal mortality prevention. The maternal mortality in Indian country is not a very bright picture right now. The pregnancy-related mortality ratio for American Indian and Alaska Native women is 28.3 maternal deaths per 100,000 live births. That means that Native women are 2 to 3 more likely to die of pregnancy and birth complications than white non-Hispanic women. And the cause of some of these deaths are specifically preterm labor and obstetrical hemorrhage rates, which can be 2 times higher than white non-Hispanic women. And the reason why some of these rates are so high is the low patient to provider ratio. It leaves pregnant people searching for providers where there might not be any. And this is where midwives can play a role and traditional birth workers. So with this, I will let Cami and Margaret introduce themselves, and we can get into our discussion about doulas and midwives. And Cami and Margaret, I'll let you take it away.
Well, thank you, everyone. So Margaret and I are both going to introduce ourselves in our way, and then we'll get started. So I first just want to humbly ask for forgiveness for my imperfect Dakota. I'm a new, working on reclaiming my language, and so doing my best. So with that, I just want to say we slumpa washte mitaki api pentu de chente washtea na page use a PA Cami Goldhammer maki api Damakota Sisituan Wapetuan Hamacha Duwamish Makocha Edwati. So good afternoon, my relatives. I come to you today with an open heart and hands. My name is Cami Goldhammer. I'm Sisseton Wapeton, and I live in the occupied territory of the Duwamish people, also known as Seattle, Washington. So I'll let Margaret introduce herself, and then I will come back.
Zoom, Giida Dana Suuzat, Tleg Udan Islan, Bedzigde Udana Islan, Tla Loga Udan Tadansulit, the Gaglisto, the Naka Hero Hodake. I am also learning my language. I introduce myself, Giida Dana, as my Danaka name. Margaret Olin Hoffman David is my English name, and I was also blessed with a Cree name, Kiho Bigwan Iskwo. So sharing my names, I'm joining you from Degayagak, Denina Lands, Anchorage, Alaska. I come from the interior part of Alaska on the Yukon and Kaikouk River areas. Our people are Koyukon. And I was raised throughout Alaska, primarily in rural areas. And like I mentioned, I'm now living and raising my family in and working on Denina Lands in Anchorage. So grateful to be here with you all. I am a midwife now. My background is in rural and Indigenous community health, where I worked for about 15 years before going to midwifery school, and birthed 3 of my 4 children along the way. And then most recently had a 2-year-old since I became a midwife.
Awesome. All right. Cool. So Margaret and I are so grateful that all of you have chosen to spend a decent amount of time with us today. I will say I was so excited when Maddie first invited me and I saw the 2-hour time chunk. I was like, oh, yay. Because I'm always like an hour. I don't even say yes to anything less than an hour at this point because it's impossible for me to stay within that time frame. But I'm just really, really grateful that all of you have chosen to spend this time with us. So our plan kind of for today is, well, and I have a few things that I wanted to say. One is I'm home alone and I have a dog and I have like workers outside and you might hear them like banging on things and then my dog will bark and I don't know, we'll just do our best. But I'm sure lots of you are used to those situations, but yeah, so we're thinking we're doing kind of a more casual conversational presentation today. We're not going to be doing formal slides or anything like that. Maddie already kind of laid the land as far as stats go. I might share a little bit more throughout what I'm going to be talking about, but I'm going to go ahead and start and share a little bit about my lactation and doula work. And then Margaret will talk about the doula work that their group is doing up in Anchorage, and then also kind of the perspective of an Indigenous midwife. So, and then we'll have lots of time, hopefully, for questions and from you all, and a more facilitated conversation. So it should be good. Yeah, so I did my introduction. I'm a licensed clinical social worker, IBCLC, which is an internationally board certified lactation consultant, or just lactation consultant, and a full spectrum Indigenous doula. And what that means for folks, well, maybe I'll kind of describe just a doula, because I know we have a really diverse group of folks that are here today. So just since we're going to be talking about doula work, both Margaret and I will be talking about our doula work, I'll kind of lay out some definitions. So the definition that I use for a doula is the definition is the Dakota word for doula, which is tuween, which is the same word as auntie. So when I think of of an Indigenous doula, we really are kind of fulfilling that traditional role of a doula, right? Or sorry, of an auntie. That if we think of our communities pre-contact, or pre-colonialism, we had very diverse, oh, someone says, spell that word, doula, thank you. We had, communities that really, the purpose of our communities was to support birthing people, right? And our newest citizens that were being born. That's what everyone kind of worked to strive to make sure that they were safe and taken care of. And so when we would deliver our babies, we would have our relatives, right, our aunties, our grandmas, our relatives that would be around us, taking care of us during that time, supporting us prenatally, supporting us, continuously through our labor as well, and then postpartum, right? All that community support would be centered around that new little family, that new dyad, and making sure that they're recovering well, and all of that. And things have shifted, right? And we could have big conversations about the impacts of colonialism on maternal child health that would be really, it'd be long conversation. But there's just lots of reasons why our communities, our birthing families maybe don't have that, right? It could be that they don't have any living relatives, and that that can support them in that way. They can maybe have unhealthy relationships, and they don't want them there. We have lots of families that are very isolated. Both Margaret and I can kind of share, as in Margaret's perspective of sharing the Alaska native birthing process of being flown, out of your community to an urban area, is kind of a different type of isolation than maybe someone who, was moved to this city in the 1950s and has no connection to their tribal community anymore, right? There's lots of different reasons why that isolation might occur. And a lot of it too is like a lot of families just don't know anymore, right? We don't really know those practices. I say asking for help is a traditional practice, but offering help and knowing how to help people and support people having their babies is also a traditional practice that was largely lost when we were forced to give up our birthing practices to the mainstream medical system, right? That's kind of the disruption that occurred. So so I just wanted to share a little bit about that. What a full spectrum Indigenous doula is, and where it's unique, is that full spectrum means that we support people throughout the perinatal period. So that includes people that are terminating pregnancies, people that are experiencing pregnancy loss, people that are trying to conceive, and a majority of the families that I serve in my doula program, or that my program serves. I'm an ED now, so I don't see as many families as I used to, but I still try and attend a lot of births and visit as many families as possible. But that's a majority of the families we see do come to us because they're pregnant and they are choosing to parent that baby. And so we provide a bulk of our families with labor and delivery and then postpartum support. So that's most of the work. So the other thing that I wanted to share a little bit about was the breastfeeding work that I do through the Indigenous Breastfeeding Counselor program or training. I know that this conversation is, the primary focus is on maternal mortality, but at the same time, our infant mortality, we have an infant mortality crisis as well within our community, and those two things are intertwined, they're interconnected, they cannot be separated from each other. And so I did want to address a little bit about that before, in addition to the doula work. So I'll just kind of start with the breastfeeding work and then move into the doula work and then pass it over to Margaret to share about your work. Does that sound okay, Margaret? Cool. Okay. And I really can talk forever. So I'm just going to keep a close eye on my clock as best as possible. I really embrace Indian time. So I'm fully in it at all times. Okay. The Indigenous Breastfeeding Counselor training, and I think I saw Candy on here, who's an Indigenous Breastfeeding Counselor. I wasn't sure if I saw any other familiar names, but the Indigenous Breastfeeding Counselor training is a 45-hour breastfeeding training that myself, Abra's here too. Awesome. Hi, Abra. A 45-hour, 5-day Indigenous breastfeeding counselor or breastfeeding counselor training that I wrote and have been putting on since September of 2017. And it was largely a result of my experience of becoming a lactation consultant, which was very interesting. I had, I won't go too much into my passion of lactation and breastfeeding, but it's just the best thing ever. And but I really wanted to become a lactation consultant because it became very clear to me as a Native mom. My oldest is just turned 13 a couple weeks ago. So 13 years ago when I became a mom and decided to breastfeed at the hospital, I hadn't even thought about how I was going to feed my baby. But deciding to breastfeed at the hospital and really having a pretty profound experience with her. It was a very spiritual experience for me. There was a lot that happened that was really, really meaningful during that time that showed me it was an important work. At that point, I was a therapist, a mental health therapist, and my area of specialty as a mental health therapist is the impacts of intergenerational trauma or historical trauma on attachment and bonding and parenting practices within the Native community. So I was doing that work as a therapist, and then had my baby, became a parent for the first time, had my baby, and breastfed, and really saw it as a missing piece to the work that I was doing. I had not ever learned anything about breastfeeding, despite being a quote, expert on attachment and bonding, right? And so it was a really interesting experience for me. But I, started my journey toward becoming a lactation consultant because I didn't know any Native lactation consultants. I started looking up information for around Native breastfeeding support for Native moms. I Googled all the different combos that you could Google, and all I got was a press release about the Navajo Nation Breastfeeding Coalition's worksite lactation program, which they passed in, I believe, 2008. They were the first tribe in the country to do that. And so I saw that press release, and then everything else I saw was photos taken in the 1800s of Native moms breastfeeding. There was just really nothing out there. So I kind of decided to start working on that path to becoming a lactation consultant, because I learned a fair amount about breastfeeding and kind of became the friend that knew a lot about breastfeeding, and just decided to kind of formalize that. But what I had really seen with the breastfeeding work was that, I was taking a 45-hour course, which is pretty standard for all lactation supporters, is to take this 5-hour course, a 5-hour course, and there's several that are offered throughout the country. But, I took the 45-hour course. I did an additional 45 hours of education. I had a internship where I did 1,000 clinical hours working directly with families at Seattle Breastfeeding Medicine. I attended a lot of conferences. There's just a lot of stuff that you have to do to become a lactation consultant. For me, I did it quickly, and it took me about 2.5 years. So most people are in the 3 to 5 year track is what most people are going to do it in. But what I really saw in that process is that, that breastfeeding is a traditional practice. And I'm sure Margaret and I will both talk about how birth is also a traditional practice, right? Or a cultural practice. We can't separate it and make it a medical event when it is a cultural or traditional practice that we had teachings and protocols and ceremony around, right? And breastfeeding is the same way. And when we look at communities that have really maintained the tradition of breastfeeding, today, the thing that they have that we don't have is grandmas that breastfed. So, communities have we see lots of breastfeeding problems. Almost everything we know about breast infections comes from the dairy industry. Like, there's a lot of stuff, information out there when it comes to breastfeeding. And that was all kind of like cultural knowledge, though, right? That we would have had because we would have seen it, where I had never seen anyone breastfeed in my life except for Buffy on Sesame Street when I was a little kid, right? But I had never seen anyone breastfeed in real life. And I really see that. And when I asked my family about our breastfeeding history, I learned that, it was my great grandmother, Mary St. Cloud, who's actually, you can't see, but she's pictured behind me, who was the last to breastfeed in our family when her children were taken to Carlisle Indian boarding school, from South Dakota and sent to Pennsylvania. And she was the last one to breastfeed. And so, with my parents, I say it was just, at their cultural knowledge of it had just been gone by the time they had me. They didn't even know it was an option, right? It wasn't even offered. And so I was really kind of looking at okay, so the reason that I didn't learn about breastfeeding from my relatives, from my family, from my, my teachers, my cultural teachers, was a result of colonialism, right? And systemic and organizational racism. And here I was literally paying white people to get this information back, right? My 45-hour course, my trainings, all the conferences I went to, my mentors. I had 2 mentors, Emily Healy and Dr. O'Hara, who were amazing. And clinically, I'm a very good lactation consultant, and I know that. But but all of the families that we served, right? Every single one was white. And I was, and that's what was hard for me to connect, is that here I was, I didn't have this information passed down to me from generation to generation as a result of colonialism. And I had to pay white people to get this education back. And that's what didn't sit right with me. And that was kind of the birth of the Indigenous breastfeeding counselor training, was really wanting to create something that was truly for us and by us, and really focus on giving the way Kim, so Kim is she's my breast friend, but she's also my partner when it comes to the breastfeeding training. And Kim is a Dene lactation consultant. She currently lives in Northern California, where her husband works for the Hoopa tribe, but her and I co-teach the Indigenous breastfeeding counselor training. And so what Kim and I when we come to communities, which we only come to communities that invite us, so we do no promotion of the training. We don't say like, we think you should think breastfeeding is important, so you should pay us to come to you. We only go where invited, and the community has to come up with, the funds to bring us there. But what we tell our students in our training kind of day one is that this is knowledge that lives in you, right? We say it lives here in your heart. All we're doing the next 5 days is connecting it to your brain, right? We're just bringing it alive and in you, because your ancestors passed this down to you, and it's just dormant, right? Like, it's just dormant, and that's okay. We have lots of traditions and teachings that lay dormant, and it's and they're just waiting for us to unearth them, right? And bring them back. And so so that's kind of the breastfeeding training and kind of the inspiration beat around it. So we have taught 19 Indigenous breastfeeding counselor trainings. Our first one was hosted by Abra, who is here, in Barrow, Alaska, in September of 2017. So that was our very first training. We trained 12 Indigenous breastfeeding counselors from Barrow and surrounding villages, and it was an incredible experience. It was so beautiful. We had no idea what we were doing and just like did it, and it was just really, really amazing. And so we just started our 4th year of teaching, because 2020 and one half of 2021 was a bust, right? So we didn't do anything then. But we've trained approximately 350 Indigenous breastfeeding counselors. And we have, next week head out on our 3rd training of this year, and we still have, oh my gosh, 9 more to do. So we're doing 12 this year. So we're really excited about this year's season. But that's just a big, really important work, particularly around infant mortality work, and we don't talk a lot about the protections that breastfeeding offers. And I have lots of opinions as to why that is, why we don't talk very openly about it. I think that we're, we don't, it's just hard. But we know that breastfeeding is extremely protective, particularly when it comes to SIDS. And so I would love to share more about it, but just wanted to talk a little bit about that work, because again, it's really intertwined. And both Margaret's doula program that Margaret co-founded, and my doula program here in Seattle, which I'll talk about next, all of them are Indigenous breastfeeding counselors. And so, this work is really important, kind of as doulas. A lot of our work is around like supporting lactation, supporting breastfeeding, because we see that as just really protective, not just for an infant, but also for a parent. There's a lot of research around the health. I don't even like to say benefits, because it's just our biological norm. So, our biological norm is to not be diabetic, to not have heart disease, to not have, right? Like, we would have access to good traditional foods and physical activity that would keep us really healthy. And so I don't really like to say that there's health benefits of breastfeeding, because again, it's our biological norm. There's just significant risk with not breastfeeding in our communities. And those are, that's some of the stuff that we want to make sure our families get off to a good start. And we also see it as very protective against maternal mood disorders, and abandonment, domestic violence, things like that. So there's just a lot of protections that are offered that, again, are very entwined with maternal mortality, right? Because our numbers here in Washington State are actually quite different than kind of the national numbers. And so here in Washington State, our Native women have significantly higher maternal mortality rates than any other group. So we, here in Washington State, according to our last maternal mortality report, which looked at similar to the, I think, dates, it was the 2017 or 2016, 2017 maternal mortality rates for our state. where Native women were 4 times more likely to die than Black women, 11 times more, our rate was 11 times of white women. You know, it's not good, you know, but we're a small population. And so technically, or kind of not technically, we often are relegated to statistically insignificant, right? And so, and that's not the numbers that really like make the news or anything like that. And so, yeah, but what we see and kind of where the mental health protections is important is about 35% of women in Washington state that die of pregnancy related causes die within the first 45 days after their baby is born. About 30% die in pregnancy, and then the rest are dying after that 45-day mark. And so, and suicide is a big portion of those, right? And so those mental health protections are extremely important, and we cannot ignore them. And then also, as doulas, we offer a lot of protections there too, because we're with that family and providing a lot of additional support to them to hopefully like mitigate some of those risks. So I'm just going to move into talking about the Hummingbird, and then I want to pass it off to Margaret. But here in Washington state, or in the Seattle area, I am the founding executive director of a nonprofit called Hummingbird Indigenous Family Services. And we have 2 programs. One is Hummingbird Nest, which is a guaranteed basic income program, which will be, is currently in the pilot phase. We'll be launching it in probably August or September, hopefully. But what it's going to do is provide a guaranteed income of approximately $1,250 a month to pregnant Native women until their child's 3rd birthday. So it is going to be the largest non-government guaranteed basic income program ever. It's no strings attached dollars. And so the families can just take the money and run, or they can choose to engage in doula services or other things, home visiting, other services that we offer. But I really hope that to talk more about that once it launches. It's going to be awesome. It's going to be epic. And I'm really, really excited about that. And billionaires are really fun to work with. That's my big takeaway from it. So billionaires who like to give away their money are fun to work with. So that's Hummingbird Nest. And then our other program is Hummingbird Indigenous Doulas. So we're a full spectrum doula program. I have 4 Indigenous doulas, in addition to myself, which again, I'm ED, so I'm trying not to do as much field work, but I just can't help it. I really love seeing families and never want to give that up. So I attended a birth last month, and I usually do a breastfeeding check with all of our families within the first couple of days after they're born. So I still like to get in there and see families because I'm just not cut out for this admin life at all, but I'm doing my best. But our program serves families in King County, which is Seattle's county. So it includes Seattle and the surrounding suburbs, right? So King County is actually fairly big. It also includes 2 tribes. So Snoqualmie and Muckleshoot, and then we have a couple other tribes that are really close by, just right outside of the county. But Seattle was an urban location for relocation during the 1950s, and so we have a very diverse Native population here. We have 29 tribes in Washington state, but in the Seattle area alone, we have over 350 tribes represented. So we have just a really diverse tribal population. There's a couple of tribes that are, we have really large populations. So Blackfeet and then Tlingit Haida. Yeah, we have a lot of folks from those communities here in Seattle. And really thriving urban community. But we, again, our full spectrum doula program, we serve families living within our county. For us, we serve pregnant people that identify as Native American, Alaska Native, Pacific Islander, and Native Hawaiian as well. And so, we really are like the fact that we just serve pregnant people with those identities is a direct result of our commitment to reducing maternal mortality rates, right? Carrying a white woman, carrying a Native baby does not put her at risk of dying, right? Like, or more at risk, right? Because let's face it, our maternal mortality rate in this country for anyone is poor, is very, very bad. So it's not just a problem of the Black and Indigenous community, but again, disparities that exist, and that's what we're focused on. But that's, we do get calls from folks with maybe a Native dad or something wanting to work with us, and we just refer them to other community members that might be better to serve them. For us, our focus is on reducing the maternal mortality rate in our state. And so that's why we only serve pregnant people who identify as Native. And so I have four doulas. We work with families as soon as they call us. So we have literally, like, I'm not joking, like literally had someone call us like one day after insemination. They were using fertility support to get pregnant. And so they like went in and then called us the next day for doula support. And then we've had people that are 41 weeks pregnant, they're due any day, and give us a call. So there's a huge range, but I will say a bulk of our families call us pretty early. We're getting more and more families that call us in the first trimester, which I think is really a testament to how loved these babies are, right? That there's a lot of messaging out there that our Native mamas don't care about their babies, that they don't come in for prenatal care, they don't, right? Kind of like all these deficits. And that's just not what we see, right? We see families that when they get pregnant, they immediately start thinking about how can we do this better, right? How can we make this baby's life better? And so people are just calling us earlier and earlier, which is so awesome. And then we work with families I really want to work with them for a minimum of 45 days. I really want to get past that one point, that point where about 35% of our mamas are dying during that time period. So I really encourage our doulas to keep working with our families. Usually people are totally cool with additional postpartum support, like they don't turn it down or anything like that. Most of the families are going to get between 8 and 12 hours of postpartum support after their baby's born. And then of course the doula is there the entire birth, so labor and delivery. And then prenatally, I know I'm kind of going backwards in a timeline, but prenatally, we usually see families minimum about twice a month. But that can really range, right? Some of our families have higher needs than others. We don't have any requirement of income or anything like that. And so we actually support families with a wide variety of, we've supported doctors, lawyers, very, very, very like well off established families, but we know that socioeconomic status is not protective against dying, right? And it's not protective against racism in the healthcare system. And so that's why we don't have a minimum or a maximum income of families that we serve. And so that's something that's really important, an important thing to take note of, because we do have some other community doula groups within our area that focus on serving folks affected by poverty or low income or low resources, and that's not necessarily us, although a majority of our families do live in poverty, right, and have a lack of economic resources. And so that is a bulk of the families we serve. Just statistically, though, that makes sense too, that would be the case. So most of our families were in their homes for about 8 to 12 hours a week for the first at least 6 to 8 weeks after their baby's born. And then we might start tapering off those visits, but it is completely family centered, right? We have some families that are actually more connected, have stronger social supports, a family, healthy family system that's there helping them. And so they may not need as much doula support, right? Our goal is never to take over where the family could be there, you know, and so we're not trying to take the place of anyone. So if they have their people there, then we want to just support and facilitate that experience. But a lot of our families don't have that, right? And a lot of our families might be alone, or completely isolated, and the doula is all they have. And so we might work with those families for more hours or for a longer time period. We're really terrible at discharging families. I don't think we've yet been like, see ya, you know, like, don't call us again. Like, I can't imagine doing that ever. We kind of say, because again, we see this as a familial relationship, right? Where they're aunties at this point. And so we're never going to just be like, we can't help you. So our oldest baby at this point is 3. And, you know, her parents call us for potty training advice, or how do I do this? And we, you know, it just really ranges on what they need support with. We incorporate a lot of traditions into our work. We have some ceremonies that we've been gifted and honored with the ability to share with families. Traditional food is a big part of our work, traditional medicines. COVID has certainly brought on an additional, you know, challenges for this whole thing, and for birthing. And I still believe that birthing families have made significant sacrifices with COVID in keeping healthcare workers healthy, which, you know, I have a lot of frustrations there. But, you know, for a lot of our hospitals, no one was allowed with the families except for a doula, right? Or except for one other support person and the doula. And so we had a lot of people calling us throughout COVID for doula support too, because their grandma couldn't be there, their sister couldn't be there, their auntie couldn't come into the birthing space, but a doula could, right? Because we were considered part of the birth team. So there's just, you know, lots that goes on there. But I'm gonna pause. I'm gonna let Margaret take over. I think, we still have plenty of time for questions, and I know there were some in the chat box. So thank you so much, everyone, for your time. Margaret, go ahead.
Yeah, Basi, Cami, I always just learn more and inspired, you know, the more that I hear your story again and again. So I'm grateful for your sharing. Also grateful for this opportunity to just talk story. When I think about my pathway into midwifery, of course, like when you're talking to a Native person, it goes back generations, right? Kind of how we heard in Cami's story too. But I think a lot of what inspired me toward midwifery started with my mom's stories. She, you know, was always sharing her stories of her experiences growing up on her land and in her language, and the impact of what it was like when she was removed from that. And, you know, later on in life when she had her first baby and then lost that first baby as a very young parent, that, you know, of course, significantly impacted her. And then also me as another one of her children, and her parenting from then on, and her sharing that story. And then, you know, there was more stories of how, you know, she almost lost one of my sisters as a baby. And this was when we were, you know, at home living in our village, which you get to by flying on a little plane, or during the summer, you can go by boat, or by winter by snow machine. But so we were pretty far out there, and she had to leave us, so me as a baby with my dad at home in the village, while she went into the city to wait and to give birth to my sister, and then, you know, brought her home as a newborn. And just struggled, you know, that first year of my sister's life with health complications of my sister. And we didn't have, you know, healthcare providers in our village. We we have, intermittently community health aides, which is a program that's been, a vital link in our healthcare system in Alaska. But we kind of had like intermittent healthcare providers in our village. And so my sister kept getting medevaced out. And just, that trauma for my mom was so impactful, and thus like impactful for me, hearing those stories. And so that desire, like I heard what a pediatrician is, because my dad's best friend is a pediatrician, and he also, told stories about how he gave me my, first vaccines and stuff. And so I knew what a pediatrician was. And I was like, okay, I want to be a pediatrician, because that's what I knew. And so I went, throughout school, went to college, with that goal. I wanted to be a pediatrician because I was so impacted of this very common story in Alaska, just of our, just some of the health challenges we have. And so I went through school, like college, thinking I wanted to be a pediatrician. My college advisor, as a freshman, or before I even started my freshman year, I walked in and said, I want to be a pediatrician. He's like, okay, you're a biology major. So I was like, okay, I went through, the biology major, and it just wasn't, I did like various summer internships and everything that were really amazing, but it just wasn't quite like sitting right, medical school. I explored all the different pathways, naturopathic, osteopathic, like different pathways. It just wasn't quite like clicking. And I ended up going to the Peace Corps after college, and I worked as a community health educator. And it was in that work that I started learning, or I guess remembering, some traditional midwifery practices, as there were, there were traditional midwives that lived around me in the rural village that I was living in Nicaragua, and working with pregnant people. And I hadn't been pregnant or, had any children yet at that point, but that's what I was, called into. And while I was doing that work, again, I was reminded of my mom's stories, growing up in rural Alaska, and just learned, it should really be the people of that community that is doing this work. Like, why am I in Nicaragua, like doing this? Like, I'm not the right person to be doing this. It should be community-led, community-based, community-led, and informed by like those local experiences. So I booked it back home and started looking for any work I could in rural community health, and started off, as a nutrition research assistant. And I'm sharing these stories, like kind of this pathway, to just kind of explain how I got to like some of the big lessons that informs my work now. But I was working in nutrition, and was trained to kind of like promote this like standard American like nutrition advice, and going out into rural communities. And it just felt weird to kind of be, just some of the standard nutrition education. It wasn't very like culturally informed at that point. And I really began to learn. I was lucky to be working with, some of the people I was working with that were, they were teaching me, really our traditional foods are the healthiest, most sustainable foods for us. And it doesn't work to take kind of like this outside knowledge and recommendations sometimes and just kind of transplant it on top of the community. I was just learning more and more like how it has to be community-based, community-led, like community informed. And really, as rural Alaska Native people, we have best practices that we've developed over living in this place for millennia, to not just survive here, but to thrive. There were stories of, people that were coming through in the early 1900s, researchers and stuff that were documenting just like how like robustly healthy our babies were, based on like our traditional foods and breastfeeding. And so we know how, like we've again been thriving in this place, and we learn from the land how to be healthy and how to be well. It's those relationships with the plants, the animals, the waters, the land, the air, and each other, depending on each other, as we're, so isolated out there sometimes, we had to. So we have, traditional ways of knowing and being really that are our best practices. So that's what I began to learn in our community health work, and began to, like promote traditional foods and traditional plants as our food and medicine. And it was really a lot of fun too. The more that we did that, the more engaged our communities became. When I was trying to do presentations as like a new grad kind of, health educator, with just kind of like some of that transplanted knowledge, like people were not as engaged. And then when we started talking about traditional foods and traditional plants, people were very excited and very hungry, like for that knowledge. Like that was what we were yearning for, myself included. And it was through that learning, I had also always kind of had this interest in, traditional plants as medicines, but did not know how to access those teachings. I was kind of, standard like American like herbalist, that I saw doing that work, and that just didn't seem accessible to me. And through get, hands-on learning with some of our plants teachers, for kind of like a household knowledge level of how to use plants, our local plants as food and medicine, I started like feeling like that traditional knowledge was accessible to me and I could incorporate it. I wasn't, promoting myself as like an expert in those areas, but we all had like a household knowledge of those ways to care for ourselves from our lands, from our plants and our animals. So through that, traditional foods work, I was also very inspired by Grandma Rita Blumenstein, who was teaching us how, about intergenerational healing, really. And it was around that time that I became pregnant with my first child. And so it was super relevant to me, like, okay, like I've known all about these negative cycles, that many of us come from, all of the disparities that we hear about in public health conferences for how like unhealthy we are. Like I know all that. And, so I was very focused, like what can I do to kind of like break those cycles? And, I was learning about just the impact of ACEs, like Cammie's work, the first, years, and even, that time in utero is so impactful for setting up a person's lifelong health. And so I was really focused on that while I was pregnant, at the same time learning about intergenerational healing. And Grandma Rita's words just like really echoed in my heart and mind all the time, how when we heal ourselves, we heal our ancestors, those that came before us and those yet to come. So even though I can't, go back in time and change the way, that my ancestors were harmed, that led to some of those like generational hurts that were passed on. Right now in this moment, like by healing myself, that reverberates back to them. I'm healing my mom, my grandmas, all the way back at the same time, the generations yet to come. And, just so inspired thinking about how when we're carrying life, as a female bodied person, or if I'm carrying like a female fetus, the eggs of the fetus are being developed while still inside of me. So potentially my grandchildren are being influenced by the way that I care for my heart and my mind and my body, while I'm pregnant with their mom. And so that was just so hopeful and inspiring to me, that I could have that impact on intergenerational healing. And that's when I realized, like, this is where I want to be, like, this is where I want to like spend my work, whatever I do for my career. I want it to be like around that, because also when people are pregnant, we tend to be really motivated for making healthy changes. And so it's just a really fun time also to work with people. So back to like the one of being a pediatrician story, like I didn't know what midwives were until I happened to be like, I was working on our Alaskan Native Health campus. This was about a year before my son was born, luckily. And there was this brown bag lunch. I happened to see a flyer. It was a doula actually that was coming to present on all of this, what I talked about, like epigenetics and how, the prenatal development period is so important, not just physically, but, mentally and everything. And so I was like, oh, that's interesting. And so I went to that brown bag lunch and there were all these midwives there. And I was like, what? There's still midwives? Like, I thought that was something that, like our grandmas did that we didn't have anymore. So I wasn't even aware of like that career pathway of midwifery until I went and I saw like real live midwives. And I was just like in awe, like, oh, there's still midwives. and that's how and then I knew, I was like, wait, when I, start having babies, like I'm going to look for a midwife. And so about a year later, we were at that phase and I was looking around for midwives, and I recognize now that I think I was really looking for, kind of somebody to mother me through that time, because I didn't have my mom at that time to fulfill that role for me. And I ended up choosing like this really like nurturing, just loving midwife. And I chose a home birth midwife because I knew I wanted kind of that holistic, more comprehensive care, rather than kind of be rushed through a clinic and just kind of, so I was very like privileged and, fortunate to know how to like look for a home birth midwife. And in Alaska, we have a lot of home birth midwives in the urban areas. Anyway, I was in Anchorage. And, of course, there were no native midwives. That was the first thing I looked for. Are there any native midwives around? No native midwives. So I found this home birth midwife that, was kind of older and very experienced and just so nurturing and so loving, but also like pretty strict. Like she really taught me how to really be responsible for my own health and in making informed decisions, that I, as a parent, am the person that has to make decisions for this little baby. And it was throughout prenatal care that she was really like making me do that. So I had to take a lot of responsibility for my care, which felt a lot different than kind of going through our healthcare system, where we're just kind of used to, like in Alaska, we have a really like comprehensive healthcare system where it's just there, and we can just go, and it's very accessible and like really good. But we're just kind of used to like doing that, going out. When I lived in Seattle for midwifery school, I kind of didn't know how to access healthcare. I just went to the Seattle Indian Health Board and it was great. But like, if it is a different experience when you're used to like being in a tribal healthcare system, and to know how to navigate that on your own. We're just kind of used to going and receiving whatever kind of care there is. So it was a big learning for me through that midwifery experience to really be looking into, all of the options, like benefits, risks of all the, decisions I was being asked to make. Because again, it's like birthing people, like young adults, we don't, if we're healthy, don't interact with the healthcare system a lot. So a lot of times pregnancy is the first time we're like really interacting with the healthcare system and getting like that intensive care through prenatal care. So anyway, it was a really big learning experience for me. And I was really grateful, for that home birth experience and that kind of midwifery care, because I felt that it really prepared me for parenting. And for drawing on, that strength that I needed to birth and to become a parent. And that kind of, again, like connected in my brain. Okay, yeah, this is where I want to be. This is where I want to be for people in my community. Because again, there were no Native midwives. So that I saw that as a gap that needed to be filled. So after the birth of my son, who's turning 13 this summer, I started just in sharing my story of my experience. Friends and family were coming to me to ask me to be with them for their pregnancies and for their birth experiences. So I just kind of got brought into that work in that way by sharing my story. People were seeking me out for support, kind of that sister role. So I started doing that, on the side of my day job and raising my family. My partner was always like 100%, supportive right from the beginning. Getting up in the middle of the night or whatever to go be with a birthing person. There were never any, like he made that possible for me too, by stepping in with parenting, like when I couldn't be there, and holding everything together, and also like taking care of me so that I could go do that. So that was super vital. So people were asking me to help them, and I was just being a sister and wanted more skills, like kind of like those technical skills for labor and birth support. So kind of started, looking at different trainings, found, DONA stuff and trainings, went to a DONA, like doula training, and it was good, for the kind of that technical information, to have some tools that I could use, when supporting people. But it was really missing the relationship piece and the kind of the heart of the work for me. And so I was looking around for like other Native groups doing this, and at the same time, working in community health and kind of trying to incorporate that in our community health programs. And there wasn't a lot that I could find at that time. I found Miss Shakthia Monroe in Portland. She's a Black midwife. She founded the International Center for Traditional Childbearing. And I went to her doula training. And that's where like that heart of the work was like started connecting for me, like how this, work is through relationship. It's not like transactional. there's like a reciprocity, in those relationships, like how Cami was talking about. These relationships are lifelong. It's not, they don't just end when a service ends, or, when, it's not a transaction. So yeah, Ms. Shafia talked about how she was supporting Tewa Women United and their doula training, getting that going. And so it just from there, like, started finding more people and more programs. And I ended up leaving Alaska and leaving my work to go to midwifery school. So it was that, and I wasn't a nurse. So it was the community work, not nursing, that got me to midwifery. All along that I had been thinking about midwifery, I actually wanted to be a home birth midwife. For all of those reasons I was sharing in my story, like, I wanted to be a home birth midwife. But as I was like looking at and thinking about my community, that's not where we are. Like, we're in the tribal health system. Like, most of us go to care through our tribal health system, again, because that's what we're used to. And nurse midwifery is the only route of midwifery that our healthcare system recognizes right now. And I began to learn that, that's a kind of a federal, like, IHS thing. It would take, really big things to happen for home birth midwifery to be recognized in our Indian Health Service and tribal health services. So because of, where our community is right now, even though I knew nurse midwifery school was really going to be missing a lot of the most important parts of education for me, that's what I chose, because that's where our community is right now. And I wanted to be serving our community. Like, I could become a home birth midwife and kind of serve not people in my community. And midwifery is hard. It's really hard work. And I did not want to be hustling like that unless it was for my people and for my community. Yeah, so we don't have any midwifery training programs in Alaska. Like kind of like in my story, I didn't even know what a midwife was until I was already done with college. I wasn't even aware that was a career pathway. And I was like pretty engaged in school and went to a lot of summer programs, and somehow totally missed that was even an option for a career pathway. So I, again, with 100% support of my partner, we had 3 kids at that time. We picked up and moved from Alaska down to Seattle, so I could do this kind of intensive, like, accelerated program. Otherwise, the other option would be to go to midwifery school online, and I knew that was not the way that I can learn. It's such a hands-on learning. I just knew it wouldn't be a good fit for me, but a lot of people do that because that's what they have available. But for me, again, we were like super privileged to be able to go down to an in-person program. So we relocated to Seattle for a little bit to be able to do that. And when I was there, I saw this call out from Nicole Gonzalez, who was the one that was supposed to be on this panel, who I like stepped in for. I saw a call out for this pre-conference gathering for Indigenous midwifery ancestral knowledge keepers. And I was like, oh, I have to get there, and found my way down there from Seattle for this gathering, and then met all these other Native midwives. I mean, it was like a handful, but it was so many, more than I'd ever seen. And it was just, the lifeline that I needed to get through midwifery school and to get started as a midwife. So I was super grateful. I'd actually talked to Nicole prior to that when I was trying to like figure out the kind of nurse midwifery versus, direct entry or like home birth midwifery. So I'd met Nicole before, but yeah, just meeting those other Native midwives was like everything, and got really motivated. Like, we have to keep having these gatherings because so many of us feel so isolated out there trying to do the work in our communities, trying to convince, the different systems that we're operating in, why this is important. So having other people, like that connection, that knowing there's other people, like kind of having this same experiences and learning from each other was so important. And so we started organizing to have that gathering at that conference every year. Also, while we were at that gathering, there was a Indigenous birth worker that invited us to her community. She hosted us in her community. And we went and then just felt how different and how powerful and how important it is to meet in community, to be hosted on somebody's land and in ceremony in that way. It was just really different than kind of a hotel like conference gathering. And so we're like, oh, okay, we have to keep doing this too. So when I moved back home from Seattle and was finishing midwifery school in Alaska, gathered up my sisters and we hosted an Indigenous birth keepers gathering here in Alaska. And so that finally brings me to the story of the Alaska Native birth workers community. So we had a gathering. We had, maybe 20-ish people from all throughout North America, actually, throughout the States and Canada. We have a lot of similarities, Alaska does, with how healthcare is set up in Canada as well, where people have to travel away from their homes and communities and support systems for birth. And so there were some Indigenous midwives from Canada that we were very fortunate to host at that gathering as well, and learn from and share support, with each other. So from that gathering, a handful of us continued to, organize, continued to meet, and continued to volunteer to work towards, filling this gap of Indigenous birth workers in our community. So in Alaska, and Abra and Twigana were here from our group, from the Alaska Native birth workers community. So I'm super grateful they're here too. So in Alaska, we have regional hospitals that serve, an entire region. And so all of the villages surrounding that kind of regional hub, people when they're pregnant can sometimes get their prenatal care in their village with community health aides that have gotten to that level of training. Again, super vital link in our healthcare system, the community health aid program. But a lot of people have to travel to their regional hub for prenatal care, for their ultrasound, for labs, or treatment for different things throughout their pregnancy. And of course, in Alaska, we live with very extreme weather and sometimes can't get to those prenatal appointments, or sometimes don't have childcare to be able to leave our homes to attend those visits, or during the pandemic, a lot of things were shut down, so a lot of prenatal care didn't happen. So there's all kinds of things for why people don't get to their prenatal visits. And then for birth, people are asked to leave their homes and communities, go to their regional hub, around 36 weeks or so, and wait there until the baby comes. And that's for a low risk, healthy pregnancy. For any high risk reason, which is defined by that regional facility. So for some people, some facilities, that means if it's somebody's first baby because their pelvis isn't proven, they're referred out to Anchorage, to our larger hospital. So about half of our births at the large hospital in Anchorage are with rural people that are referred into care here for a high risk reason, whatever that may be. Sorry, I don't know how to turn off that sound without turning off the sound of our meeting too. So that's been going on for generations now. Birth being removed from our communities. And so I really think about how that impacts our education for normal pregnancy and birth growing up. Siblings are not seeing their siblings being born. They're, not being involved with the prenatal care of that pregnant person, because that care is referred out of the community. And so just think about how that impacts kind of the community's understanding around supporting pregnant and postpartum, people. It's kind of like assumed the healthcare system will do that. And so a lot of those traditional ways of knowing how to support our family, it's been like disrupted. And, not just for birth, but I think about the prenatal support and the postpartum support after they're coming home, the breastfeeding support, a lot of those roles, community support roles, kind of peer support roles have kind of been displaced. And I think a lot about like the impacts of colonialism and how our traditional midwives, our traditional birth attendants were devalued. And so a lot of that information has gone to sleep. And that's what we're trying to remember now, is reconnect those traditional roles for supporting our family. For remembering those best practices as people that have been in this place since the beginning, for how we keep each other well and healthy, and how that is so important for impacting generations. So that's why we do what we do. So the Alaskan birth workers community, again, it started off very intentionally community-based. We're not through any other organization. We didn't have any funding or, to start. We all started as volunteers with this shared mission. And we did it as a collective. We have a consensus leadership model that we operate by. We don't have a hierarchical kind of leadership. It was very intentionally community-based and co-founded by this group. And we just started off like doing what we can. We had volunteer doulas that by word of mouth were able to start going and being with people during their birth experience. If they're here alone or whatever, social support reason, we could be there. And so we started off as volunteers. And as we were kind of getting more organized and growing, our capacity kind of matched the amount of requests that we were getting. And again, it was just like word of mouth at the beginning, very grassroots. And as we got more organized, we started getting more funding, and have now been able to contract full-time Indigenous birth helpers, the first of which is Abra, who's here. And now we have Tuigana, who's another one. And so we have some people that get to do this for their day jobs now. It's not on the side of their other day jobs anymore, or in taking care of their families. We get to compensate for their time in this vital role that they're now like serving in our community. So the Alaskan Native birth workers community has kind of three support areas. There's direct service, where we, families can request that direct kind of like one-on-one support from us, and they can be matched with an Indigenous birth helper anytime in their preconception through postpartum phase or through a pregnancy loss or, whatever reproductive, health experience they're going through. And they want somebody there with them. We can be there with them in that community-based, peer-to-peer relationship. We also host community talking circles, and that was a big, kind of pivot with the pandemic. A lot of things went online. Also, a lot of pregnant people were being isolated. People, again, coming from rural areas that were in town waiting, were now having to be in their hotel rooms like alone, and so even more isolated than before. And so we tried to keep holding community space, through all these new virtual platforms that have come out. So we've had just a open space, unstructured talking circle that's been going on every other Saturday. I don't remember when the first one was, maybe Abra does, but for a few years now as a response to the pandemic. So yeah, since the beginning of 2020. Another way that we help is by helping stock a donation closet and emergency food bags. What are some other direct service areas? And then kind of second sister, so like the three sisters, first sister, direct service, second sister, training more Indigenous birth workers. So that was our, kind of next big goal, is bringing more people into this pathway. Whereas for myself, there wasn't anybody, in Alaska that I could look to for this. And so now we're trying to bring more awareness of these traditional roles and reclaiming them, and revaluing them, and offering pathways, into these roles. And so we had planned to host a couple of trainings in 2020. One of them was the Indigenous breastfeeding counselor training. And then we also hosted the full spectrum Indigenous doula training with Ziggy Dewin in Alberta with Melissa Brown and Candace Newman. So we had both of those trainings lined up in 2020. Of course, they got postponed, and we were able to complete them last year in 2021. And so we have a trainee group that we're trying to mentor along the way, and have been bringing them into this work as we're trying to get more people back into these roles, whether they choose midwifery, whether they choose, obstetrics or, or whatever part of it. We have no judgment or care. We just want more of our community members in these roles that are serving families. And then the third sister is kind of more systemic, advocacy. What can we do to promote? Yeah, there's the links. Let's see, Kimmy. For looking at, systemic issues, because it's not, the disparities that happen. It's not the responsibility or the fault of the families that they're experiencing those disparities. They're systemic, so we have to address them that way too. So I can put in. Can we have participants? Do Abra and Twigana want to add anything else that I've missed for our A and BC work?
Hi, I don't miss anything. I'm just grateful that you were able to jump in and share about the work that we do. It's just been so special to be a part of this community work and this heart work. And yeah, I wanted to be a doula for a long time, and then was able to live at the prematernal home, live there. I managed the prematernal home, and I lived there with pregnant people on the North Slope for years. That's when I met Cami, and it's just been really wonderful to do this here in Anchorage, or Dagayakuk is the Dena'ina word for Anchorage. And it's exciting to think about how we can keep expanding across the state, because Alaska is almost just insurmountably large compared to the lower. I mean, people always talk about how big Alaska is, but it's hard to understand when you don't live here, or even when you do live here, just how the barriers of just having a baby, like people have even shared in the chat how hard that can be. And it just being there for people through that, but then also, like Margaret already talked about, like reclaiming those roles so people feel supported. It's so important. So I don't have anything extra, but Koyanakpuk, Margaret and Cami, so good to hear from you. And yeah.
See, Albert, thanks for jumping in, even right on the spot. Yeah, so ANBC, our team right now is located in Anchorage. And so the in-person services, are only as far as we can drive from here, within an hour or so. But the online talking circles, of course, we are trying to reach as much of Alaska as we can. We've had participants from Atka, way out on the Aleutian chain, to Utqiagvik, the very most northern point in North America. So like over 1,000 miles apart. We've been able to connect people virtually. And then the trainings that we've hosted, we've had, dozens of communities represented in those trainings. And the other thing with Alaska is we're so diverse culturally. We have so many languages and different cultural groups. And as the birth workers that are part of this group, we're all representing, parts of those, but not all of them. And so we're really looking for more community representation throughout Alaska, and hope to grow to be able to provide more in-person services, as we're getting more people back, or like inspiring people back into these roles and supporting them and stepping into them in their own communities. So we're primarily located in Anchorage, and providing in-person services here, but hoping for like a statewide reach and representation. Basi.
Okay, thank you, Margaret and Cami, so much for sharing your stories, your information, your knowledge, your experience, and your advice and recommendations. I really appreciate you taking the time to to come sit and chat with us today. I wanted to ask a couple questions because as I was talking earlier, explaining to you kind of while we were off away from the presentation, we at NIHB serve as the representatives of Indian country to our policymakers on the Hill and kind of in those federal levels. And how could we, and what kind of resources, for example, funding, training, technical assistance, are needed to expand the birthing workforce and increase Indigenous representation in doulas and midwiferys and the lower 48 and in Alaska as well?
Well, I think
So much.
so much. I would, I think one of one of the first things that needs to happen is we absolutely need to increase access to midwifery care. Something that we see in our doula program here, and I say this with an immense amount of privilege living in the Seattle area. Like, I know that Seattle is not rural Alaska or Oklahoma, I understand that. And we live in, I call it a birth bubble here in Seattle, right? Like, we're in this little spot where literally doulas move here to doula because everyone uses a doula, and like people can get jobs here type thing. But, we, in our doula program, about 30% of our families choose out of hospital births. And that is not their intention when they first come to our program. And we don't do any sort of, although I will, I am also a home birther. And so there's certainly potentially some personal bias there that I'm willing to acknowledge. And three of my 4 doulas have all delivered at home as well, their babies at home. So we're in this kind of like unique group where I thought I was like the only Indian to ever deliver at home. And then, Margaret and I met like, I don't know, 10 years ago. And it was like, oh my God, you're me, but in Alaska. And, and like, there's just like all these kind of moments, like Margaret said, of meeting other birth workers, and you no longer feel isolated of like, you're this like unicorn, who is the only one doing what you do, or parenting the way you do, or birthing the way you do. But I had never met like another Native person that had a home birth. Anyway, like, I think that we really do need, thinking at the federal level, looking at the different options that our families have, because there actually are quite a bit of home birth midwives in rural communities, right? Like, that is actually like how a lot of people still deliver their babies, except for the natives, right? Except for us, like we're not necessarily utilizing that. And that doesn't necessarily speak to just what's happening within IHS and the federal level and how insurance pays for it, or how people know what options they are. I find that most families have no idea that they have any freedom to choose who they deliver with, right? Our families come into IHS, they take a pregnancy test, they get proof of pregnancy. And then if they are in a system that catches babies, they typically stay within that system, right? But we know that there's only about 13 IHS hospitals that catch babies. There's the Alaska hospitals and the Oklahoma hospitals that are tribally run that catch babies. But a majority do deliver in general population hospitals, and they're referred out, right? In our communities, most are referred out to the general population, and they just go to who they're referred to. And I kind of have been saying for a long time of like, why do we keep sending our families to providers that don't take care of them, right? Like, it's acceptable to me that we refer our families to providers and they don't come back feeling loved, feeling sacred, feeling secure, feeling safe, breastfeeding, right? Most of them come back to us traumatized, not breastfeeding, just kind of grateful that they're alive, which I say, and some of you have heard me speak before, like I say, surviving childbirth is a very low standard, right? And it's actually not that hard to meet that standard. But we want, if we think about this as ceremony and as a traditional practice, then our families should be moving into that ceremony of giving birth and bringing a baby to this world. And they should be doing that in a way that makes them feel safe and secure and loved and sacred, right? Which is what they are. But we just kind of keep sending our people to like whoever and accept that that's okay. And again, I know that there's a lack of resources. I know that sometimes there is just that one person, but I just find we have very low standards for our community, like when it comes to maternal child health. Like, we speak a lot about caring about moms and babies, or women and babies, and we just don't see that happening. But yeah, I mean, I know Margaret could speak to, more around like the the barriers with insurance, and, you know, that there was, you know, like she spoke about how she chose nurse midwifery as a path specifically because there was no other way to work within the Indian health system, you know, as a home birth midwife. And that's not okay. Like, our families should be able to choose where to deliver, who to deliver with, and they should be able to do that in the safety of their home or another family member's home. We have a lot of families that deliver in other people's homes. I mean, it's just like beautiful once they kind of learn that they have the power to make that decision, right? That they don't have to go with who they went with. But the number of families that I meet that deliver with the same provider that traumatized them with the previous births, you know, and they don't even think that they have another option, right? And that's what's so hard. Like, we just really want to empower families there. But I would love to see more options. I would love to see nurse midwives at the Seattle Indian Health Board. I would love to see home birth midwives as an option. I would love to see partnership between those communities too, right? Because a lot of times it's like, I'm choosing home birth, but then, you know, about 25% of first-time home births actually do transfer to a hospital. There needs to be a partnership there, right? And a connection and a way for these families to be cared for. But yeah, Margaret, go ahead.
Oh, same thing. I just, you know, availability of options. I was going to say, you know, recognizing home birth or certified professional midwives or licensed midwives within our tribal health systems would really increase access to midwifery. You know, midwifery is one of the most sustainable practices for delivering reproductive and maternal health, maternity health care. So training and recognition of, you know, all types of midwives was what I was, gonna emphasize.
Yeah. And then, you know, just increasing access to doula support, you know, not that there's so many challenges that are contributing to the maternal mortality, you know, like numbers that we have. But the one thing that I do know is that it's not the fault of Native women, right? It's not us. It's not that we're, you know, I know I've said this before, it tends to be my soapbox I stand on, but, you know, it's not that we're, you know, sick and unhealthy and to all the bad things you can think of. Like, it is not our fault that we're dying, right? It's just not. But too often the messaging that comes out really blames the birthing person for dying or for getting sick or doing, you know, like whatever happens. And that's what, you know, so I know that there are multiple things that are happening that are contributing to this crisis. But again, the one thing I do know is it's not the fault of Native women, right? And life givers. It's not our fault. But doulas can be very protective, right? My doulas, and this is where I differentiate between like Indigenous doulas versus like mainstream doulas, right? Like, or kind of like what a lot of people think of when they think of doulas, like white, hippie, like the whole thing. Like Indigenous doulas, like, again, we're aunties, right? And so we are advocating for families. If you do a mainstream doula training, you're going to be told, like, you're the hands behind the hands. You're not to speak over a client. You should coach you know, like, sure, go over things with a client, you know, but it's not your position to voice or advocate for them. That's for them to do. And you should be empowering them to do that. We don't roll that way, right? Like our Indigenous doulas, like, we're aunties and we are going to, I mean, yeah, like, we do advocate for our families. It can be rough. It can be rough out there, you know, like as an Indigenous doula in these hospitals. But we see our role as protectors, you know, and then that postpartum support is so important. It is I don't even know, injustice, disgusting, horrible practice that people give birth and they are not seen for 6 weeks in the mainstream medical system, right? That's standard. You give birth to a baby and you go home and that parent is not seen for 6 weeks, right? Until for their postpartum appointment. And then that's just like the okay, you're okay to have sex appointment, right? Like there's not really any, like substantial information that's given there. And then they're never seen until they get pregnant again, right? Or their next annual exam, which is now every 3 years for most of us, right? Like that kind of thing. And so doulas or home visitors or midwife, the midwifery model of care is like you're seen 24 hours, 72 hours, 1 week, right? And you're seen often throughout that 6-week period. And so we need to do something there. Like we have to provide something where families are being seen, are being cared for during that time, because it's so critical, right? Like it's just an injustice that we accept that is okay, right? And just like you're a parent for 1 day and then you're just sent home, and even in the most wonderful, I always say, like for me, like I was in the best situation to have my kids. I became pregnant when I wanted to become pregnant, right? I chose to become a parent, and that's when I got pregnant. I have an awesome partner like Margaret. We literally live parallel lives. And, like awesome partner, established career, financially secure, just like kind of like all the check boxes, and it's still hard. Like it was still so hard. And yeah, I'm just thinking about what we do. And so I would love to see some shifts there, and like how often we're seeing families. But I just know that not seeing a person that just delivered their baby for 6 weeks after they have their child is just not okay. It's just not okay, right? And especially when 35% of our moms die in that time period, right? I mean, like 45 days, that's 6 weeks. Like we have to do something there and see more families, right? And not just like hover over them and that kind of thing. Like see them and provide support to them and love on them. And doulas can play a really important role in that, right? That could be a doula's role. That could be a community health worker's or a home visitor's role. It doesn't need to be a trained medical provider, but someone needs to be caring for that person during that time period.
Yeah, thank you. I completely agree that the sterility of the biomedical world and structure and all that is not conducive to healthy motherhood and healthy pregnancies and healthy children. And we're definitely seeing the ramifications of that, unfortunately. Katie, I want to call on you to unmute yourself and ask your question about doula trainings as traditional health workers and reimbursable services.
Thank you. Can you hear me okay?
Yes, we can.
Okay. Okay, guys. So I've been sitting here for an hour and 45 minutes, like screaming. Okay. First of all, my name is Katie Morioka. I'm a women's health nurse practitioner. And I have a doctorate in nursing, and I am the public health director for the Confederated Tribes of the Umatilla Indian Reservation in Northeastern Oregon. So I'm in the process of trying to use funding from another grant that is getting ready to go into its last year. I'm robbing Peter to pay Paul, so to speak, to be able to get a doula program up and running for this community. And I am not a tribal member, and I am struggling with, I need to train doulas, and I'm going to have to start this program from scratch. And here's the situation that I find myself in terms of I need to find, I have a doula who's willing to train, and she is the stereotypical doula that Cami was just talking about. I was giggling because she is a fantastic, white hippie, right? Like she just is. She's great.
great.
Well, she's
White
great.
hippie is great. Yeah.
But she's a white hippie, and I love her. She's really fun. But I obviously in Oregon, so there is a traditional health worker. This is the standard model in which doula services can be reimbursable, and in order for us to be able to make this program sustainable. And so doulas they do have to become sort of certified doulas underneath the traditional health worker, under that umbrella as a traditional health worker in order to be a billable service. And so I'm trying to find a doula training program that we could potentially be able to get into, most likely into 2023. But one, really and truly in starting this program from the ground up, we have had home visiting programs in the past. And due to COVID and multitude of other reasons, we're down to only having, one person currently in that role. So, I mean, it's a long story. It's a lot of drama that nobody here needs to really hear about. But I'm interested in, when I click on some of these links about some of these doula trainings, they're in, New Mexico, and they're only training, local people in New Mexico. And obviously, it's a little cost prohibitive to be able to do some of these trainings in Alaska. And so in order to be able to make this, I have to be able to make this make financial sense, right? I mean, in all reality, yes, our pregnant women do get transferred to the local hospital at 30 weeks. My ultimate goal is to be able to send every woman who leaves our clinic with a doula who's going to go to those prenatal visits with her, who are going to close that prenatal loop and continue with these women postpartum and continue to keep them engaged, both culturally and medically. And I've worked at that local hospital. Like, I get it. Like, I am that provider who could, I mean, even as a women's health nurse practitioner, I purposely did not become a midwife when I went back to school. I purposely did not become a midwife because I knew I wouldn't be able to stay in my community and practice, because our hospital was not going to allow a certified nurse midwife in the door. And so, I mean, I understand that. So, but the best I can do now for this community and the community in which I'm serving, the best thing I can do now is to be able to help close that loop for them. And so, and give them someone that can help them navigate that system. I can't fix the system right now, but I can do this. And so really what I'm curious about, and what I kind of, while everyone was here, is to kind of, is anybody else started one of these programs like this from scratch? And if so, like, where do I start? Because this is, it's an uphill battle. I have to be able to get doulas into the hospital alone, which is going to be a fight. But I think we're in a unique situation that if anybody's willing to fight that hospital, it's me, because I've worked there. So, I mean, I think that's a good thing, because I think there's enough people there who have a healthy fear of me that I think we'll be okay.
Yes. Yeah. Do you want to answer, Margaret, and then I can, or do you want me to?
We both, Cami and I, have started these doula programs. For us, we, like I was mentioning, intentionally organized from the community up. So ourselves as Native birthing people, and kind of passionate for this cause, came together to do that. So we already have that commitment to and relationship in serving our community. And that was really important for us, in whoever came alongside us to do this work, that it's based like through that relationship. So that's like one of our foundational values that we're really guided by, is that this work is through relationship with our community as members of this community too. Like, this is our family, this is our life, this isn't our day job. It doesn't go away, when we leave an office. I don't have an office for that work, but it's our life that we're immersed in. We can't turn it off, which is very different from, when I go to my clinical job in the clinic or the hospital, for the other people that I work with there that are not part of this community. Yeah, so I was getting distracted by myself, but so we decided to organize from the community up, and we intentionally didn't go through any other organizations because we didn't want to have restrictions for how we decide to use our funding. So once we just started doing this, a lot of people, funders wanted to support the work. And we also were very conscious about not ever having any kind of cash transaction with any of the families that we serve with. That's just not a traditional value that we could live with. We don't do traditional medicine with that kind of transaction. It's through relationship. So we don't work with anybody's insurance or anything like that. I'm not the best to know about that. I know Cami knows a lot about reimbursement, but we are able to offer these services with the grants and stuff that we get. So we pay the birth workers, and it was very important to us that we pay them a living wage. The standard, kind of doula fees when people are doing this work on their own in the community, which is super important, but they have to, have fees to sustain their work. It's for it to actually be a living wage for them has to be really high fees, and we just can't do that in our community. And the role of an Indigenous birth worker is so vital. We value it so much that we not only does it have to be a living wage, but we have to value their position in the community and knowledge that they carry that's just different from kind of a standard birth worker in the community. Aubrey says part of the thing about starting is that it needs to be community led for it to be sustainable. Yeah. So I don't know if that helps, but we went about it by not really thinking about having families pay or working with their insurances, but by using our grant funding that we were able to get, because so many people do want to support this work, and then paying the birth workers themselves a good wage so they want to keep doing this work too, or able to live off of it.
Yeah, and I can kind of share how we do it. So Hummingbird is also grant funded. And so, Katie, I know Oregon has a licensure bill that will pay for doula services with Medicaid dollars. There's a lot of challenges because the reimbursement rate is not that great. So like Margaret said, that living wage for a doula is really, really important. And so far, all of the Medicaid bills that have been passed in states, and there's only a handful that have, the reimbursement rate is pathetic, not even close to appropriate. We actually just passed we called it Doulas for All here in Washington, that was signed by the governor a couple of weeks ago, that was Black and Indigenous led. So myself and my team, as well as some Black doulas, were led the work and were heavily involved in the process. And so we actually have a great reimbursement rate through Medicaid. It has not been implemented yet. We're still it was just signed by the governor a few weeks ago. So we still have a little while to go before we actually can bill Medicaid for doula support, but the reimbursement will be equitable. So it's a good amount. The other thing that, for Katie, for you specifically for Oregon, is that Oregon's law, and I think you were getting at this with the trainings a little bit, is that they have to be certified doulas, which is a just like straight up colonial system. So DONA is the doulas of North America, I think is what DONA stands for, which is kind of the one that has been anointed, right? Because all of this is made up, right? It's all pretend in like this weird, system, but they're the ones who have been anointed with like the ones that determine if a doula can be certified or uncertified or whatever that is. So all of the Indigenous doula trainings that I put in the chat, none of them are DONA certified. My doula program, I do not require DONA certification at all. And because we are grant funded, I don't have to worry about anything like that. But I think, for you specifically, Katie, like, because you're in Oregon and you are likely going to need to be utilizing Medicaid dollars to help to fund your program, right? Your doula, at the very least, supplement, right, the income that doula might be making, then chances are you are going to have to utilize a more mainstream doula program, doula training. There's a lot out there. You can do, honestly, just do a Google search, and pretty much anyone that comes up is going to be DONA certified, because they're all white and they're all led by white folks. And so they all do that process, right? It's kind of just like Indigenous and Black doulas that are like, we don't want to do that system. So there's a lot of them are online. They run about $500 to $800 for a 4-day training. So it's not, I call it an entry level gig, right? Like, you don't need to have any sort of prior education or work experience to do this work. But, thinking about the doulas that you potentially will train, that's something to think about. When we were training my doula for my doula program, I did have funding to do a training. And so I had Zuggy Dewin come down to Seattle, and we trained 40 Indigenous doulas. And then that was my hiring pool, right? Like, cause I was, that was at the beginning, before I was still designing my doula program at that time. I had a 6-month design program or design period, because we were a community design program. So it was specifically funded. They were specifically funding community design programs. So not best practices, not evidence-based, right? These were programs that the community themselves designed. So I was creating the doula program. So I had Zuggy Dewin come down, paid for them to come down, opened it up to the community, right? And I had 40 Native women that wanted to become doulas, right? Like, they were there. And then again, that was my hiring pool. I could just hire 2 doulas at that time, but I was like, I'm going to bring the training here, and then I will have a bunch of people to choose from. And that's exactly what happened, right? Within that pool, I had about 15 interested in the position, which is way better than me having to like find one person that's interested, right? Or like that kind of thing. I really wanted a hiring pool. I wanted people to choose from that, I can make the best decision. And then for me too, like, knowing we were one of the first like urban doula programs, Native doula programs, because there's a few tribes that have been doing doula programs for a long time. There's obviously the Alaskan Native birth worker community based in Anchorage, which is technically urban, although it's Anchorage. So it's Anchorage by Alaska, or urban by Alaska standards, right? But and then there's a doula training based out of Minneapolis as well, a doula program, Indigenous doula program based out of Minneapolis. But I knew that kind of like, when developing it, that there wasn't really anything else. So I wanted to set the standards really high. So I was like, I'm going to go like super extra on this doula program and make it just as bomb as I possibly could. But I also, wanted to create a lot of stuff that didn't exist out there. So things like paperwork, and this is something, Katie, I put, and anyone else on here, I put my email in the chat, and Margaret, you should put yours in there too. But you know, I've developed intake forms, consent forms, disclosure forms, charting, you know, like prenatal chart forms, birth forms, postpartum forms, like for visits, for tracking, because it is a little different. Like doulas are not a medical provider, but when you are a part of a program, you do have to have some protections in place, right? Like we are grant funded, so I do need to show my funder that we're seeing families, right? And be able to document the hours that we spend with families, that kind of stuff. And so I've already done that. I'm happy to pass any of that on to you. You all can just like keep it and just take my logo off. Like, I don't really care. It's not proprietary information at all. It's just like, who wants to develop paperwork? I know I didn't want to, but I was forced into it because no one else had done it. And so now, you know, like now it's out there. And so that can kind of be helpful. And I'm also really happy to just like talk offline about what we've done, but grant funding is huge. I gotta say too, like our tribes need to step up, right? Like if you're working, you know, you're working for Umatilla, but like there are other tribes, like our tribes do have money to support birthing people. Doulas are not expensive. Like 1 to 2 doulas for a tribe should be enough to like cover that family. You're talking, you pay them 60 grand a year, right? Give them some money to make some traditional foods and things like that. This is not an expensive project and it saves lives. And tribes need to step up. Our councils need to step up and allocate funds to it. And we need to be putting pressure on them to do that, right? I'm in an urban area, so that's not necessarily what I get to do, but you better believe our urban, you know, our tribes that are close by, I'm in there saying like, you need to do this, right? So right now I'm in talks with Tulalip to have a Tulalip doula, right? They're outside of our service area, but you know, they're going to fund a doula position. We're going to provide all the technical assistance and support, and they're going to be a part of our team and training and things like that. But, you know, I'd say just look at, again, Katie, like look at a mainstream doula training, because that's what they're going to need to get Medicaid reimbursement in Oregon, and then supplement that training, because it's going to be like the worst for that native doula to have to sit through a training like that, but supplement it by sending them to these other Indigenous doula trainings, right? Connecting, we have a really active native birth worker or Indigenous birth worker community. We're on Facebook. There are thousands of us. Like there's a lot. And I swear for a long time, it was just like a handful here and there. So there are options, but yeah, there's a lot of internal politics within the doula world and the birth world, and it is a very colonial system. And so we're constantly having to kind of like be in a place. I'm also really lucky, like the Alaskan Native birth workers community, to just kind of like throw up our middle fingers and be like, we don't need to be a part of your system, right? Like I don't need to. I'm good. I have a funder. They're happy, you know, paying us to do this work, and it's really great. But I understand that not all of us are in that position, right? Like we do have to be able to work within the system sometimes too. And there's ways to do that and still serve community.
Thank
Now
you
we're
so
out of
much.
time, but just one more like kind of mind frame switch that has to happen with this work too is from like a quantitative way of thinking to qualitative. That was one of the barriers to starting a doula program at our hospital here, was that they were wanting like a really high quantity, you know, number of births to be served by the doulas. And this work is just, it's so deep, like to be on call for somebody and to have that relationship with them and to like be able to be with them like so intensively. It's really like high quality, but not high quantity. So I just wanted to say that too.
Yeah. Cool. I think that's it. But yeah, you guys are great. Good luck with everything. And yeah, just I see too, like we don't need permission to bring doulas to our births. Like I mean, back in the day when it was like a little sketchy or a little weird or not as friendly for doulas, like I'd walk in, or as a lactation consultant, I'd get called in. people would say, who is this? And they say, that's my auntie, that's my cousin. They don't need to know, like they don't need to know that you're the doula, like that kind of thing. We don't need to ask permission for this kind of stuff. And we really need to empower families to exercise their right as sovereign people, right? Like, and to have this, yeah.
Thank you, Cami. And oh no, I think that's a great point to end on, is we do not need to ask permission for our health. And this was really beneficial and it was a great discussion. I know we are 5 minutes over time. I wish we could keep going, but we will have plenty of opportunity for this conversation to continue in the near future. So I encourage everyone to please sign up for our NIHB newsletter, that you will hear future events around maternal mortality prevention. Again, please reach out to your support networks if you felt like this conversation was a little heavy today. I know I felt that. So, please utilize those networks as you can. And thank you again for everyone being here. The recordings will be posted online once the conference concludes. And again, please, if you have time, feel free to fill out the evaluation. It should be there by now, but I might have to upload it. And again, I offer Cami and Margaret to say their goodbyes as well.
Hoksha, everyone. Thank you.
Talk to you later.
Thank you.